important in the field, and to make sure that people know what sort of resources are out there, what kind of cool people exist in the field, right? And we've got one of those here today with Tony Coder, who is not only our brand new prevention and public health division chair, but also the executive director of the Ohio Suicide Prevention Foundation. So we are really lucky, I think, as AAS to have Tony to come on the board, but I'm also really lucky to have him here today so that we can ask questions and we can talk about things and we can talk about what Tony does and what you like. It's clear that you like sports, so that might come up later down, down this
Yeah, I
afternoon.
love them. So,
But thank you, Tony, for joining us.
hey, thank you so much, Chris. And likewise, I'm really excited to be on the board of AAS and get to know, a lot of cool folks that I haven't had the opportunity to interact with, including you. We had a great conversation, about 10 minutes, and a little bit about Larry Bird and all kinds of fun stuff. So excited to be here today.
Yeah. So Tony, let's just kick it off. Let's get rolling here. And if you could just tell us a little bit about yourself, how you got involved there in Ohio and with suicide prevention in general.
Yeah, my background is mainly politics, and worked with Governor Bob Taft and and his wife, First Lady Hope Taft, and she led a lot of prevention programs in the state of Ohio, and I was her only project manager, and then continued with policy work. I was the director of legislation for the Ohio Department of Job and Family Services under Governor Ted Strickland. So I worked for one Republican and one Democrat,
There you
and then uh, ended up doing some prevention work and some national work around policy. And it's been quite frankly, never thought I would see myself in this field. But 3 years ago, my son had some issues with mental health. He diagnosed as bipolar, and and has had some experiences with suicidality, and it was something that I just I had to do. And what got me was he said, "Dad, would you do it for me and kids like me?" He's 26 years old now, so it was something I had to do, and I want to make sure that systems are changed so that he has a better opportunity to receive quality care than what he did the first time.
Yeah, kids have a really strong tendency to use what they need to make us do what we have to do. So, but that's really interesting. And I think a lot of people would join you in this field, and I'm sure that you understand that at this point from your work that so many people have been affected, and that it's really something that we need to address in effective ways. It sounds like coming from the policy place and the sort of political arena that you come with like really unique ideas. You come from a unique perspective. How has that sort of shaped where you come in there in Ohio or now in a national level? Like, how has that helped you sort of figure out what you want to accomplish and what you want to do?
Well, I think obviously policy is important. System change. We can have all the programs and the research and everything else. Hey, great to have you here, Jackie. We are so glad that you're able to join us today. Impacted family, um, but we definitely need system change. How are we reaching hospitals? How are we reaching physicians, workplaces, schools? All of these different places, and I bring that, I think, to the table. A lot of different relationships. Relationships are the number one piece of what, I guess, the most important thing about what we do is build relationships. I don't like singing just to the choir, where
Mhm.
a bunch of us are in the room and we've heard the same QPR, the same whatever talk by whomever. But instead, how are we reaching out to organizations across Ohio and now nationally? And then, as you and I were talking, Chris, I don't behavioral health folks. Advocacy is is something a little bit. You do it differently than
Mhm.
folks who have been, like myself, who've been in politics or policy work. So, I hope to bring that to different areas here at AAS, and also fundraising. I was telling you earlier that, when I first started as executive director of the Ohio Suicide Prevention Foundation, from what I understand, we had $4,000 in the account. I didn't know that. And now we have a budget of $5 million a year. So, being able to, money, helps an awful lot in spreading our message, and being able to have conversations, and also even bringing partners into the field as well.
Yeah, you can't drive the car if you can't afford gasoline, right? So
Exactly.
I think one of the things that's really, and we don't talk about it. I don't talk about it enough on here, but we certainly in the field don't talk about policy work enough. We have some really great peers in the field who do a lot of policy work. AAS has been pretty active in policy work over the last couple of years, legislation and working with individual folks, but it's something that really does make a huge difference. And again, I think it comes from that sort of impacted sort of component. A lot of the folks I know that we've worked with at a national and regional and local levels are folks who have been impacted, right? These are folks who want to sponsor a bill because they have been personally affected in some way.
Mhm.
And creating those relationships with those folks is really, really important. Um, and coming at it from that sort of a background of knowing, like, okay, well, this is how a bill gets, introduced into a committee, and what happens if it doesn't get out of committee? Does it go back or does it go forward? Right. So, having that sort of background, I think, is super helpful when looking at what we need to do at a larger scale to really make an impact.
Well, and I, if you look at drunk driving, I mean, what changed the conversation about drunk driving? It was
Yeah.
a bunch of moms and dads who said, "We are sick and tired of this. We're sick and tired of being second class citizens, of our kids getting killed." This is the same thing. Jackie being on with impacted family. Folks who have that voice of experience, whether through loss or through their own attempt or a family's attempt, those are the folks to me that are going to get things done, because legislators listen to people. And I've had that actually happen. I've met with a senator, and I remember one time he was talking, he was letting me do my testimony. He stopped me in my testimony and he said, Coder, I know who you are. I want to hear them. You're a lobbyist. You are, I want to hear from them in another position I was in. So we started Family Advocates for Suicide Prevention in Ohio, and we recently started that probably 3 or 4 months ago. And again, I believe that the voice, if we train them well and if we give them great talking points and they're able to share that story effectively, that is going to change the conversation, break that stigma, and really get some policy work done that just hasn't been done right in this country before.
Yeah, yeah, and we're seeing some like major changes in that direction. We've seen over the last year or so, 988, right? That's the big one everybody is talking about. Introduction of a mental health, a sort of 911.
Mhm.
Where we've seen a lot of assistance and support for veterans and for youth suicide prevention. So, in a lot of different contexts, there are some really great things going on. So I think it's going to be a really exciting time, here in the next 2 or 3, 4 years to see what sort of legislation starts getting pumped out. But 988 is where it starts. I mean, everyone's talking about that. So.
Absolutely.
Um, Tony, what sort of things, like we talked about, you do come from a different perspective. What sort of things do you hope to accomplish on the AAS board?
I hope to get more conversations nationally around policy, and not only policy at the legislative level, but workplace policies, policies, in hospital settings, even in behavioral health care settings. I really hope that we can, at least what I would love to do is be able to really break down the stigma that still surrounds this topic. When I first, when my son had his, when he spent his time in a mental health facility, it was something. Again, I come from a governor's office and a lot of lobbyists, and that this wasn't supposed to happen to families like mine. Well, I go to funerals all over the state now because I want to keep that personal touch of folks who are losing loved ones to suicide. And you know what? I met some of the best families in the world through this. This happens to anybody and everybody, not just we I think have this stereotype about who is who is suicidal and all of this kind of stuff, and where do what kind of families people come from. But when you're talking about mental illness, it is it's a mean disease. I say that all the time. I stole it from Terry Russell from NAMI. It's a mean disease. It is it's gonna get anybody at any time, and we really need to be there to have that conversation. And I hope to do that at a national level with AAS.
Yeah, it's something that sort of always keeps us humble in this field, is that, knowing that even outside of mental illness or mental health issues, that people can be affected.
Hmm.
Environmental impacts, we know, are big, big risk factors. So just this idea that being able to know that folks, or have a scenario where people know resources and supports that exist, and if we can be effective in providing those kinds of things, at a wide scale and it pretty consistently, I think that's a noble goal, and I think that's absolutely in line with what AAS's mission is, I think, for most suicide prevention folks.
Hmm.
um, yeah, and Patty made a good point, like I had just mentioned, that mental illness doesn't always play a role. I think it was the CDC in 2018 mentioned that more than half of people who had died from suicide did not have a diagnosed mental health issue at the time of death. So we know that, and especially right now with everything going on with the pandemic and political issues and all sorts of other things, that people are stressed out. People are dealing with a lot of emotional strife and turmoil. So being able to provide those supports and resources is super important right now.
Yeah, and I agree. I mean, it's everything that's going on. I mean, I meet folks who, financial issues, unemployment, stuff that's going on with social justice, folks trying to get equality, and I mean, it really is everything that's especially right now is coming to ahead an awful lot, and we as a country, I think, have ignored. Um, we as a country have ignored a lot of issues, and we need to work through. We talk about I don't think there's enough talk about suicide in the African American community, and those are some issues we need to bring up. We have a very large refugee population in Columbus, Ohio. I rarely see anything on that. So we need to begin those conversations and have them to where they're culturally competent. Can't be the white guy from Columbus, Ohio coming in, but it's got to be done from a lens of that's culturally appropriate. So I really do. I mean, just so many things going on. And Patty, thank you so much. You're exactly right. It isn't just mental illness. Again, my son is kind of what my go-to is. But I also experience a lot of folks who have lost people with no history of mental illness, but instead just pressures of life or whatever else that they might be dealing with.
Yeah. And you're talking about some things that I think we all want to see change, and we talked about this with Jackie too, is that so much of what we've been doing over the last 50 years hasn't really shown to be largely successful in lowering the rate of suicide in the country. We've seen a couple of dips, potential dip in 2020, but we have to take all of that within statistical lens and look at trends and all that stuff. So um, almost went on a tangent. I'll reel it back in. Um, but yeah, so we talked about some things that definitely need to change in terms of equity and increased diversity, access, right? But are there some other things in the field that you really want to set as a priority to change?
I think marrying research to communications. My wife is a research. She's a scientific researcher on genetics and things like that, and it's fascinating to me. I keep telling her that we need each other. That research without communication, and communication's a science. Everybody thinks they can do it, but it really is a science. But research without communication is a book that sits on a shelf. Communication without research is a bunch of things that are going out there that might, that probably aren't effective. So we need to marry these things, and we need to understand that we need each other, and that we really need to work together. That we don't have a couple different camps of doers and researchers. Instead, how do we come together? How do we use the research to influence what we do at the federal, state, and local level, so that we can save lives. Uh, and also be an example, I think, across the world. I read something on the International Association of Suicide Prevention, and 1 out of 100 people die by suicide in the world. My God, that's just pretty startling stat when you think about the numbers of people that are in the world, and it's really really something that we need to be an example here in the United States, to other parts of the world, and show that research, when meeting communications, really can do wonderful wonderful things.
Yeah, and that's a great point, and it's definitely something that I'm passionate about. So I'm glad that we're on the same page with that. Obviously, research is so critical to a relatively nascent field like suicide prevention is, and being able to communicate important findings,
Hmm.
and explain efficiently why what we're seeing is important,
Hmm.
and how we can implement it and how it can affect people at scale. These are all these are all things that are super important going forward. But that last part, that meeting of implementation with the research too, is part of that communications deal. Like, how do you have to be able to find that Lego piece that connects the others, right? And so implementation and communication are going to be critical here.
Hmm.
We have tons of research about treatment methodologies and things that work, um, if they're supported with funding, if they're supported with infrastructure and all that. But if we're not doing a good job at explaining why those are so important and how they're saving lives,
Hmm.
then no one's going to pick them up.
Right, exactly. And even with prevention, um, you know, there are different kinds of prevention. There's everything from primary prevention, which is before anybody has any kind of symptoms, or has shown any signs of suicidality. It's that upstream. And then there's intervention. That was the hardest thing for me to grasp, when because I was coming from a job that was more on the substance misuse side. And when I came over here, I thought, oh, okay, prevention is, getting people before they start and all of this kind of stuff. And really, suicide prevention is much more of an intervention type of field. It's
Hmm.
PR, it's Working Minds, it's all of these different programs. And I think we also need to marry those. Be accepting of you know prevention across the span here of suicidality. That some people, yes, they will get them in that primary prevention, where we'll teach resiliency and strengths-based skills and all of that stuff. And then, but then there are other folks that we're gonna get, and we're gonna try to literally help get them to treatment. Again, that's prevention. So I think that is also something that could be explored, as the public or the prevention programs in public health. I would love to have that conversation about how we use a public health approach in not only the primary prevention, but also the intervention piece of prevention as well.
Yeah, absolutely. That ecological model is really key for what we're looking for, and in terms of this public health approach. And then, like, again, it sort of all melds together with what we're talking about in terms of increased access to healthcare, increased access to job security, or any number of different things, food scarcity, income inequality. Like, all of these things sort of play in this public health sphere, that if we're not looking at from a really big perspective, we're going to be missing some of these things. I mean, one of the conversations I always had coming from a crisis background was this follow-up piece, right? And after you've had a conversation with someone, and you've intervened, right? You've hit that intervention piece, and you've gotten them into some sort of treatment, whatever it is, whether it's the hospital, whether it's a behavioral health center down the line, whatever it is. If you aren't continuing to have those conversations with them, or if they're not having a continuum of care set up for them, what that means is they go to the ER, and then they get discharged back into the same environment that led them there.
Hmm.
So if we're not, and if it's, if they're in that place because they lost their job, or because of a relationship issue, or whatever the case, if
Hmm.
we're not working with that person to help them live in a world that they want to live in, then we're not doing our jobs either.
Right. Absolutely. And I think again we go back to culture. I know with we work closely with the Bhutanese Nepali community. We have this in Columbus. We have uh, I think it's the second largest Bhutanese Nepali community. And because of the stigma around suicide, we don't actually talk about suicide. We talk about gambling. We talk about um, issues around alcohol because they're open to having those types of conversations. But it really is something that I think having being able to have that conversation in language and in subjects that are appropriate and that are accepting to that culture, I think is also really, really crucial to us reaching populations we never have before.
I think it's important. One of the biggest pieces of what you're talking about too is that it's important to not just be focusing and adapt to the audience and the population that you're working with. But I think, even at population scale, yes, we absolutely need to be having public prevention, or public health and prevention conversations. We also need to be having those individual conversations, that we can look at these big level interventions, but what it comes down to is that each person is going to have some level of individual intervention,
Hmm.
even within those audiences and those populations.
Hmm.
There is no one size fits all to this whole thing. So bringing it all together under the umbrella of things like public health and policy, and all of that's going to be really important.
Well, and I also think that we need to come up with something that I'm reading Mary Margaret's 1 in 100. That's what I had read, and she said it's 10.5 per 100,000. Again, I think we need to that's what the stat I received. Come up with some kind of what is the truth around this? Because there's
Mm,
so many things, especially on the internet. Good Lord, there's so many things on the internet that are that people believe that might be true, might not be true. Being I that's what I really, really am excited about being with AAS. How do we really get truthful information out there? Not to use an overused term from last year or 2 year, whenever it was. The whole fake news thing. How do we get that factual and quality information out there, as well as strategies to be able to that communities can utilize across the country.
yeah. Well, I think we're hitting on something that a lot of people don't like to talk about, and that data collection and analysis in this country are really terrible.
Hmm.
There is no there's no real good system in place right now that allows us to get real-time data.
Mhm.
Um, I think I just did some quick googling too. 10.5. I'm not sure what year that was. I just looked up on who this year in June. More than 700,000 people die every year. So we can, again, and that's worldwide, but we can go back and forth about
Yeah.
numbers and statistics. But sort of what you're saying. I mean, we run into some data collection problems. I know here in the States pretty frequently.
Yep.
That each one of our states has different reporting procedures that go either through a medical examiner or a coroner, sometimes both.
Mhm.
Those then have to be consolidated, sometimes in a committee structure, where then those are voted on as to whether they are counted as a suicide by consensus. Like and that's just one form of one state, right?
Mhm.
And I can't tell you which state that is. I literally can't. I don't remember,
Mhm.
because it's different every state.
Right.
You have multiple people who might be responsible, or one person who's responsible for handling all of the coroner or medical examiner issues for 40 to 50 counties, depending
Mhm.
on rurality.
Mhm.
So you have that situation, and then those are reported up to the federal level or regional level first. We don't know. It's all sort of a mystery. It's all sort of a structural like anomaly, right?
Mhm.
So we have an issue just based on that. That's not even going into the conversation where we're talking about how we qualify or how we classify what counts as a suicide. How many of these deaths of despair and overdoses are suicides, but we'll just never know,
Absolutely.
right? So there's just so many issues with this ability to do that. Not to mention that there's no general one-stop source outside of the CDC to find these things. We were talking with Jeff Thompson with NYPD on Friday, and that data collection for law enforcement officers is all over the place, even more so than it is for the general public.
Mhm. Mhm.
And we have to rely on a third party private organization to collect that information. That's not how it should be. Like it
Right.
should be a lot cleaner than that.
Absolutely. Yeah, we have, I talk to coroners, and, you know, I was told by, one coroner, that another coroner will never report a suicide because of the stigma that comes around. And that's, kinda sad. And going back to the whole issue around, opiates and overdoses, if we could really get to that some are intentional as opposed to everything being accidental. I think it also gives us, just from a health perspective, um, a much better reaction, to overdoses. That, I know, a lot of times, we'll Narcan a person. That's extremely valuable. You can't, get to you can't help treat anybody who is not here anymore. So, instead of just Narcanning, is this an opportunity if we could, see that, wow, 20 to 30%, which I think Nora Volkow from the National Institute of Drug Abuse, estimated that 20 to 30% of our overdoses are actually intentional as opposed to accidental. That kind of changes the way that we even look at, our problems. That it's okay, maybe we just don't need to Narcan somebody, but maybe how can we have some conversations around suicide, some conversations around treatments, whether it's mental health or just above substance misuse treatment. So I think it's kind of interesting that, how this could all morph if we actually have some good data.
Right. Well, and yeah, I mean, targeting, treatment targeting or intervention targeting is something that obviously is one of the goals of effective data analysis, and we're not able to do it because our latest data that we have is 2 years old at a
Hmm.
national level.
Hmm.
And we regularly don't see finalized data until 18 months to 2 years.
Right.
By the time that we receive that data, either at a statewide level or nationally, it is far too late to
Yep.
target interventions and treatment.
Yep.
It's far too late to talk about, okay, well, it's not too late necessarily, but it's a little too late to do anything in real time.
Hmm.
So we can look at data from 2008
Mhm.
and say this is how it potentially affect, the economic crash potentially affected suicide rates in the country. But by that time, it's 2010.
Mhm.
Economic changes have already occurred.
Mhm.
People have either already found different jobs, or have stabilized or not, right?
Mhm.
So like that's one of the biggest issues, and I think from a public health perspective, it's something that I think we have just too much work to do,
Mhm.
and not enough focus on. I think we're focusing on some very important things, of course, but I think data collection, real-time data collection analysis is in re-envisioning our surveillance structure
Mhm.
has to be a priority.
Absolutely, which goes back, right back to me to policy work. How do we get those policies changed? How do we get Congress or even state government or even our local coroners to change the way that they're reporting things? How can we get them more involved in whether it's suicide prevention coalitions or whether it's statewide work? I know our state received what's called a syndromic surveillance system where they can
Yep.
actually look at suicide attempts in hospitals. I think they're like a day behind. But I mean, that's the type of data we need because, especially with a pandemic, I mean, my gosh, if we're getting 2000, you know, 2019 data, I mean, the pandemic has just changed everything, the way we do things, the way we look at things, the, depression and anxiety rates, everything. So, yeah, having 2-year data is helpful, but not the greatest help.
Well, and I've had conversations obviously since the pandemic started with folks at hospital levels, or at public health levels, and my question is, okay, well, if we're able to have real-time data on COVID deaths and hospitalizations and all, like any number of tiers of information in real time, why can't we have that for suicide? And
Absolutely.
the responses I've heard have been like, oh, well, that happens at the hospital level. They report that data, and I'm like, okay, well, why can't we do that for suicide? What are we doing? Why not? Why can't we do that for attempts? Good Lord. I mean, if we're able to, if we want to talk about numbers, in the States, we have 48, anywhere between 45 to 50,000 a year
Mhm.
of deaths. And we are looking probably closer to 1.2 or 1.5 million attempts,
Mhm.
right? So these are people who are who are struggling just as much as someone who has unfortunately died from suicide,
Mhm.
and we're not looking at those with the same priority as we are with deaths. So I think, looking at not just the surveillance of deaths, but also in attempts
Mhm.
and those with diagnosed suicidality or anything like that. Like we have a lot of work to do to sort of shift this around and see what information we're not looking for and what we haven't asked for either, right? I mean, we may not even know what we actually need.
Exactly. And that's why, that's some of the conversation I hope we have at AAS that we can maybe push for.
I think it's one that I regularly scream into the abyss at. So I think this is something that we could definitely have some conversations about. Um, well, Tony, is there anything else that you want to leave our audience with today? And again, the folks who are watching now, please feel free to leave questions. If you want to leave questions after the fact, we'll make sure Tony gets them too. But before we head out, Tony, is there anything you want folks to know?
I think, again, my whole thing is on relationships. The other piece is, I try to surround myself. I'm not, I don't have an ego large enough that I have to be the smartest guy in the room. As we can, we're gonna be having, prevention programs and public health conversations and calls and such, and would love to learn from other people as well as have a community that we share. And there might be ideas that are different from mine. There are things that I want to learn. There are things that from a policy side I might be able to teach, or to share anyway. And I just really am excited that we again, I'm able to hopefully we're able to gather these folks and be able to spread this message. No judgments. No even if there are disagreements, we, still go away happy with one another, that we're still in the field. We're still, our mission is still the same, that we're trying to save lives every day. And also that we break down some silos, that, because, uh, they might not agree with something, that, again, mission comes first. And, it's a lot of different ways that you can slice a cake. Um, but at the end of the day, we just want to be able to save lives. So, knocking down those silos, having honest conversations, and being able to use everyone's voice, everyone's knowledge. And let's, again, do it for my kid, for your mom, your dad, aunt, uncle, friend, family, whatever. That's who we're here for, to save lives. So, Jackie, I am very glad to be on the board as well, and I'm looking forward to working with you, Chris, and everyone who's part of AAS.
Absolutely. I think that's a great way to end our conversation today, Tony. Thanks again for jumping on and chatting with us, and for letting us to get to know you a little bit better. I think it was hopefully it was enlightening for me. Hopefully it was for other folks who jumped on. And like I said, if anybody wants to reach out, let us know, and we'll get you in touch with Tony.
Excellent. Thanks so much, Chris.
All right. Take